It's actually afforded me a little bit of luxury on reflecting on what it means to have a quote unquote successful program to provide home-based newborn care to India's newborns, but identifying failures which may have deterred this successful program in reaching its true outcomes.
You're listening to Fail Loud, a series that draws insights from failures in the development sector. Brought to you by SELCO Foundation's Impact Failure Platform. In this episode, we try to understand the success in the delivery of home-based newborn care and its less apparent failures, as told by Dr. Rajani Ved, the Director of Health at Bill and Melinda Gates Foundation during Impact Failure 2022. The story Dr. Rajani Ved, the Director of Health at Bill and Melinda Gates Foundation, India, narrates starts in 1993 with a pilot program implemented by an NGO called Search in Gadchiroli in Maharashtra. The program leveraged community health workers who were trained to provide care for mothers and newborns. At the time, 95% of deliveries in Gadchiroli happened at home and were undertaken by DAIs or traditional birth workers. Newborn deaths, also called neonatal mortality or NMR, occur within the first month of life. Shockingly, 2/5 of all deaths among children under 5 happen during this period, and 75% of these are preventable. In the early 90s, Search implemented the Home-Based Newborn Care or HBNC pilot in Gadchiroli, Maharashtra, where community health workers, better known as ASHA workers, were trained to provide home-based care for mothers and newborns in 39 villages. In rural areas, one ASHA worker is mapped per 1,000 population, and urban areas, one ASHA worker per 2,500 population. Since 2005, over 1 million ASHAs have been trained under the National Rural Health Mission or NRHM.
At that time in Gadchiroli, 95% of deliveries did occur at home, and so DAIs were undertaking the deliveries, and these specially trained community health workers undertook newborn care.
The impact of ASHA workers was seen over a span of a decade, when neonatal mortality dropped from 62% to 25%. A follow-up pilot in Maharashtra showed a similar 51% decline. Between 2005 and 2009, Search collaborated with government ministries in 5 states, where they tested 3 different approaches. One using Anganwadi workers, another replicating the original community health worker model, and the third continuing this usual system. Only the community health worker model achieved significant reduction in neonatal mortality, and by 2011, HBNC became a part of the National ASHA program.
Now, 3 rounds of the National Family Health Survey demonstrated. So in 2005, when NRHM was launched, the NMR in India was 44. In 2015-16, it came down to 30. And in the latest round of NFHS, it's about 25. Now, not all of these declines are attributable directly to the ASHA, unlike in the original pilot, where because there were very few other interventions other than high and very robust referral systems to a healthcare facility, very little of it was similar to the pilot. So my objective in the next few minutes is going to share with you the challenges of scaling up a pilot intervention from a well-run, well-managed NGO program in a few villages to a national program, and then having managed the introduction of the scaling up, how do you sustain the scaling up? And therein lie the failure lessons.
The critical period for newborns is the first day, the first week, and the first month of life. At the time, institutional deliveries were low, and even when they occurred, mothers and babies often returned home within 24 hours.
The realization that high proportion of newborn deaths are preventable and reducing, and so the policy of the National Health Mission at that time included these following components, saying that NMR in high mortality settings with weak health systems, and many of the same states that Rachna showed you, could be undertaken with robust community outreach, the provision of home-based care, supporting mothers and caregivers to improve home care practices, and ensuring access to hospital-based care. Now, it just looks like 4 components, but extremely complex. Each one of these components is an extremely complex intervention.
In this context, community-based care is essential. The Gachiroli model featured trained women community health workers who received 31 days of modular training over a year that was interspersed by learning on the field. They conducted frequent home visits to the houses of newborns, from birth to 6 weeks. The workers of Gachiroli were authorized to administer antibiotics, manage asphyxia with bag and mask ventilation, and receive robust supervision in supplies, performance-based payments, and on-the-job monitoring. The model had to be simplified when it was scaled up. For instance, the training was reduced to 20 days, but including additional training that provided her with skills in actually managing a newborn. They added an equipment kit to the ASHA, and we must consider what an enormous task it is to procure the equipment kit and ensure it reaches every ASHA in the village.
To sustain the spirit of the intervention and ensure fidelity to training. Again, a humongous task. Most state governments resisted the idea of sending their trainers all the way to Gadchiroli to be trained, but we insisted on it and we were able to get this. And this made a huge difference to the way that at least the cadre of state trainers who were able to go back and train the next cadre of trainers in the field, because we do cascade training. And commensurately, there was also an expansion of newborn care corners, sick-born care, newborn units in healthcare facilities. This is needed. Not all newborns can be managed at home. Many of them do need referrals.
Scaling up home-based newborn care also involved extensive negotiations, as the training infrastructure was inadequate and supervisory mechanisms were already stretched. To address this, training was moved to the sub-block levels, and residential programs were introduced to build solidarity among ASHAs. However, all was not smooth, and resistance came from multiple quarters.
Oh, how will we train so many ASHAs? We don't have the training infrastructure to do it. Our existing supervisory mechanisms are already overstretched, and therefore we said, well, then let's get in new supervisory cadres, and we were able to be successful in that. We got one facilitator for every 20 ASHAs. Orissa, Jharkhand all have one facilitator at the rate of 10 ASHAs, which is much better. There were concerns over creating new mechanisms for training because we insisted on moving training to the sub-block levels so that ASHAs would be able to come. And we also insisted on residential training because it builds a sense of solidarity among community health workers to be trained together.
Doctors expressed concerns over handing over tasks like administering antibiotics to non-medical workers.
There was a lot of pushback from doctors, of course. Professional privilege, you're handing over this equipment to the kit. Har Asha ko doctor banaoge kya? This was a common refrain. We also had competing priorities. WHO, UNICEF had a model of integrated management of newborn and childhood management. Now that didn't entail so many skills. And therefore that model was being pushed, and there was this constant comparison about they're doing this and the government is proposing this. What do you really want?
Civil society argued that ASHAs were shifting from their activist mobilizer role, therefore giving poor care to poor communities. And policy advocates questioned the need for newborn care when there were maternity entitlements like Janani Suraksha Yojana that encouraged institutional deliveries. Evidence alone wasn't enough to scale up HBNC. The process required negotiation, contestation, and ongoing consultation. System readiness was often overlooked.
Assessing system readiness, I think there was a bit of a hurry there. And there's always this trade-off, is the system ready? Can we introduce this and then get the system ready? How do you decide? It depends on context. It's messy and iterative. Large-scale implementation implies quality loss. Systematic scaling up. Now that was a lesson. Developing standardized protocols, modules, having training programs that were structured in place, criteria for selection of trainers, all that does go a long way towards scaling up a program.
Over time, ASHA's responsibilities have expanded from 4 tasks in 2005 to over 40 tasks today. These include maternal and newborn care, tuberculosis follow-ups, non-communicable disease screenings, and more. While ASHA's commitment is admirable, structuring their workload remains a challenge. And while HBNC has shown promise in reducing newborn mortality, scaling it up has exposed gaps in training, supervision, and system readiness. Moving forward, addressing quality loss, ensuring adequate support for ASHAs, and organizing their workload is critical to sustaining the program's success. SELCO Foundation invites organizations and individuals to come forward and share their impact failure stories and to fail loud.